Hi, good morning. I'm so pleased to be here. My name is Johanna Gray, and I am a vice president at CRD Associates, which is a lobbying and consulting firm in DC. I work with several patient advocacy and provider groups, including another in the cancer space, the International Myeloma Foundation. And so I'm here today to talk to you a little bit about everyone's favorite topic, the Affordable Care Act, and their second favorite topic, navigating health insurance. There's a lot of hyperbole floating around about the ACA, so I'm going to spend a few minutes telling you kind of the facts about where we are today and where we're going, and what you as patients and caregivers want to keep in mind as you're choosing an insurance plan. So first, what's happening today, and then based on what kind of insurance you have now, what you need to keep in mind. So what is happening this fall? Of course, the health insurance marketplaces, one of the cornerstone pieces of the ACA, the marketplace is opened for open enrollment on October 1st. This is the website of healthcare.gov, where people can go to purchase health insurance. I hear some snickering in the audience, which means that, of course, all of you know that the implementation and the rollout of the marketplaces hasn't gone quite as smoothly as many had hoped. I'll talk a little bit about that. That may be an understatement to say it's not going smoothly. But the marketplaces are open, and if you want a health insurance plan that kicks in January 1st, then you have until December 15th to pick a new plan. So there's plenty of time between now and then, hopefully, for all the kinks to be worked out. Of course, many other health insurance plans are also having their open enrollment period now. I know that's true in Medicare, many private insurance through employers. If you have a choice, the open enrollment is probably now. So I think it's a great time for you to be having your conference and for us to chat a bit about what you want to keep in mind. So what's right around the corner? 2014 is when lots of the reforms in the ACA kick in. The marketplace plan coverage starts on January 1st, if you pick a plan by December 15th, as I said. Open enrollment continues until March 31st, so people who don't need insurance to kick in right away have until March 31st to pick a plan in open enrollment. The Medicaid Expansion takes effect, and those states that are choosing to expand Medicaid coverage. Also, the individual mandate takes effect next year, which is the requirement that you have a health insurance plan or pay a penalty. The penalty next year is $95 or 1% of a person's income. And the second part is what seems to get lost in the shuffle. I think that there are some people who say, well, $95 is a lot cheaper than a health insurance premium, so I'll just choose to pay that and hope I stay healthy. But it's 1% of your income, whichever's higher. So folks that have higher incomes could pay a much larger fee than $95. Also, many private insurance reforms take effect next year for plans in and outside of the marketplace, such as no pre-existing conditions exclusions. There are new rating rules, so plans aren't allowed to charge you more in premiums based on your gender or based on your health status. The essential health benefits requires that plans, again, in and outside the marketplace, be comprehensive. Before, people would purchase health insurance plans, think they were comprehensive, and then they would get sick, and it turns out, oh, I don't actually have prescription benefits, even though I thought I did, or there were no maternity benefits, or there were a variety of situations. As a result of the EHB, plans now have to be comprehensive. This has been in the news a lot in the last week or so. Some folks think that maybe that's not important, that people should be able to pick plans that cover just what they need. But for better or worse, plans overall will be more comprehensive starting next year. Plans can have no lifetime or annual dollar limits on coverage, which is huge for folks who have cancer, who have other rare diseases, other chronic conditions. I mean, as all of you in the room know, unfortunately, very well, you can reach $1 million lifetime cap pretty quickly if something catastrophic happens to you or your family. So this was a reform that I think lots of folks are excited about. One thing to keep in mind is there is a category of plans called grandfathered plans, which are exempt from almost everything I just said. Grandfathered plans are those that existed when the ACA was signed in March 2010. So if your plan existed in March 2010 and hasn't changed since then, it can be grandfathered and can continue to offer what it did before. If you're in a grandfathered plan, the plan has to tell you. So you should know if you are. The other thing to know is that the number of grandfathered plans is decreasing each year. Insurers make all kinds of changes every year, just separate from the ACA. And so they defined who could be grandfathered pretty narrowly, so it's not affecting that many people anymore. I wanted to highlight a few reforms that I think particularly benefit cancer patients or have the potential to. One is the limit on out-of-pocket expenses. So starting next year, the ACA limits out-of-pocket expenses to $6,350 for individuals, or double that for a family for next year. The number will increase a little bit each year, so for 2015 it'll probably be about $6,400. So this means your deductibles, your co-payments, and your co-insurance. Before, lots of people never had a limit at all on what their out-of-pocket expenses can be. So this should make it a little more predictable that you know kind of at the outer edge what your healthcare costs could be for the year. That figure doesn't include what you spend on your premiums. So obviously when you're picking a plan, you'll need to think about both what the premium costs are as well as what the co-pays, co-insurance, deductibles, all that stuff. This policy applies broadly to plans starting next year. So it doesn't apply to grandfathered plans, but it applies pretty much to everyone else, including large group plans, employer-sponsored insurance. The only trick is that the limits only apply to in-network services. So it's really important when you're picking a plan to make sure you understand if your doctors are in network. If you're seeing a physician who's not included in your plan's network, you'll probably have to pay more for those services, and that spending does not count towards the cap. So you could meet the $6,300 and then however much in addition. There's also some flexibility just for next year for large group plans that currently have 2 plan administrators. This is starting to get pretty wonky, but there's large group plans frequently work with companies to help administer their benefits. So if if a plan works with 2 insurers, someone does the pharmacy benefit, someone does the medical benefit, those plans can have 2 caps for next year. So if you're in one of those plans, it could be $12,000. And I'm sure you're thinking that this is still a lot of money, and it is, absolutely, but compared to before when there could be no limits and, unfortunately spending could increase forever, this gives a little more predictability. Another reform that applies to lots of plans next year relates to clinical trials coverage. So starting next year, health plans must cover, quote, routine costs for qualified individuals participating in approved clinical trials. Before the ACA was passed, in about 30 states plus DC, there were requirements that plans allow enrollees to participate in clinical trials and to cover the costs if they do so, but it wasn't everywhere. It wasn't all plans, and so this is broad coverage starting next year. You can see this slide kind of defines who, so it's qualified individuals. Well, who is that, and what kinds of trials and what kinds of costs? So you can see that it is defined in a particular way, but the bottom line is, hopefully it should be easier to access clinical trials next year from your insurance perspective, that your insurance plan will have to allow you to do so, and that they'll have to be able to cover your healthcare costs while you're in the trial. So I think this also has potential to help folks. So moving now to the marketplaces. So these are the big things that opened this fall. The important thing to know about marketplaces or exchanges, they're called different things in different states. There is one in every state. As I'm sure you know, there are some states that are setting up their own marketplaces. In this map, they are the kind of teal color. So on the West Coast and then on the East Coast. These are states that are setting up their own marketplaces. They are setting up their own rules. They have their own websites and phone numbers. They, in many cases, seem to be running more smoothly over the past month than the federally facilitated marketplaces. Those are the pink color. Those are states where the state isn't doing anything to set up the marketplace. It's all the federal government in charge. The purpley color in the middle are the partnership marketplaces where the states are doing some of the work and the federal government is doing some. Why it matters, what kind of marketplace your state has, is that the rules differ for plans based on whether it's a federal marketplace or a state marketplace, and then where you go as a consumer or an advocate changes as well. So in the case of the teal states, as I said, the states are setting up the marketplace. They have their own websites. Some of them are entities that have existed for years now, and you can go and learn a lot about what's happening in your state. Others, on the federal government side, it's healthcare.gov, of course, the kind of famously difficult website. But so there will be a marketplace in your state, and who's in charge makes a difference. So how are marketplaces supposed to function? So if all goes well, people are supposed to be able to go and they can apply online, in person, or over the phone. Healthcare.gov is a place to start. That is the website. I showed a picture of it on my first slide, where consumers will go. There's a no wrong door policy, which means that if you're a consumer, you can go to a marketplace and you don't need to know what you can qualify for. So for example, there are tax credits and subsidies to help people purchase health insurance, and they vary based on income. You don't need to know what you're eligible for to check the boxes. You just enter your information. Again, if all goes well, there's a computer that does math in the background and then tells you, here's what you're eligible for. Some people go to the marketplace and it turns out they're really eligible for Medicaid or other public health programs. So you can go to the marketplace even if you're not quite sure what your situation is and then enroll in a plan. Yes?
I believe you said that there is a difference in whether you go to a federal or a state marketplace.
Mm-hmm.
In what respect are there differences other than one's handled by the federal government, one's handled by the state government?
So the question is, I said there was a difference between federal and state marketplaces. What's an example of what I mean the differences are? From the consumer side, the website will look different. It'll have a different name. The state marketplaces frequently have like punny names based on the state. So that's, I think, kind of clever. Like I know in Kentucky, their marketplace is called Connect. So the website will be different. There's a different phone number. There are different, from the plan side, there are different rules about the kinds of plans that can be offered. But from your perspective, it'll just look different. The application is the same regardless of where you go, but the consumer experience will be a little bit different. So the last thing about marketplaces is that there are people who are trained to help consumers navigate the process. If you go to localhelp.healthcare.gov, you can type in your zip code and find out who in your area has received the training. Okay, so this is, of course, how everything is supposed to work. So how is it actually working? We're in open enrollment. How open the enrollment is varies widely by state. There are some states where things are running pretty smoothly. I mentioned Kentucky. Kentucky seems to have worked all of this out and it's running smoothly. In other states and for the federal marketplaces at healthcare.gov, of course it has not been running smoothly, and I'm sure you've all read the articles, so I won't belabor the point. But it's not going very smoothly. I know many people are very frustrated about it. We know that millions of people are going to healthcare.gov. I suspect half of these 20 million people are lobbyists and reporters who are going to gather information. I can tell you I'm responsible for like 5 million of these myself. We know that lots of people have filled out applications, but it's a multi-step process, and so the number of people who've actually picked a plan, the $1 million question, we don't know the answer. I read yesterday that one think tank estimates about 150,000 people have enrolled in plans on the state level. We don't know how many people have enrolled in plans on the federal marketplaces. They're not saying. It came out yesterday that apparently in the first 24 hours at healthcare.gov, the number of people who enrolled in plans was 6 million. No, literally 6. So, that's concerning. They haven't said how many people have enrolled since then. This is all still to be seen. There is still some time for the kinks to be worked out. Experts were saying that they thought we had about until Thanksgiving for all the website problems to be fixed, because that would give people a couple weeks to still pick a plan that would start by January 1st. Conveniently enough, that's also about when the Obama administration says they think everything will be worked out. They've said the end of November now is the goal. So we'll have to see. I mean, my advice is to be patient. You can try and click on the website today. I don't know if it will work for you. I think if, giving it a couple more weeks is probably wise just for your own frustration. But again, we still have 6 weeks for you to pick a plan, and so, there's some time. So who should enter the marketplace? I think another thing to keep in mind, which hopefully can be reassuring, lots of people don't have to do anything. People who have if you have insurance that you like, then you're set. If your insurance plan is still available to you, you can leave all of this mess behind. But if you're uninsured, or if you have health insurance that you don't like, that's expensive or maybe doesn't cover what you need, it may be worth, frustration aside, logging onto your state's marketplace and do some exploration about what plans are available to you. So very briefly, to cover on a couple other types of insurance, so Medicaid will be expanded next year in some states. The Supreme Court, when it ruled that the ACA was constitutional last summer, made the Medicaid expansion optional for states. It's really 2 expansions. One is to childless adults. Medicaid has historically been a program for children and moms. So this allows childless adults in some states to get coverage. It also increases the income level for people who are eligible for Medicaid to 138% of the federal poverty level. There are some other reforms that will happen to Medicaid in states that are expanding or not. Their eligibility and enrollment systems are being updated. There's going to be some synchronizing with the marketplace so that people can go there and find out what they're eligible for, as I mentioned before. Also, the essential health benefits policy I mentioned that requires plans to be comprehensive also applies to Medicaid as well. So Medicaid managed care plans will be more comprehensive next year. So where do states stand on the Medicaid expansion? So this map, let's see. So all the blue colors are states that are expanding Medicaid coverage or leaning to do so. The darker the color, the more decided. The purple in the middle are states that are expanding Medicaid coverage but are considering different models. So for example, in Arkansas, they wanted to expand Medicaid coverage but then use the additional resources they're getting from the federal government to allow people to buy private market plans on the marketplace. So I believe that was approved in Arkansas, and you can see there's a handful of other purple states following suit. And then the red states are those which are not expanding, intending to expand next year. So as I said, this is optional for states. There's some kind of free money in it for them, at least in the short term if they do. I think most folks think that in the end, most states are likely to expand Medicaid. When the Children's Health Insurance Program was first enacted, it was also optional. About half the states implemented it right away, and then as time went on, more and more states were added. So while this is where we are today, and Ohio just decided to expand Medicaid about a week ago, this is still a fluid situation and will be fluid in years to come. So for Medicare, the prescription drug donut hole is closing by 2020, and there are discounts when you're in the donut hole in the meantime. I know that's something lots of folks were excited about. The thing about Medicare is lots of the ACA reforms have to do with physician reimbursement and new payment models and stuff like that. So there are fewer kind of consumer-directed reforms in the ACA. There are new screenings and wellness visits that are free without a copay if you're a Medicare beneficiary. One potential negative thing is that Medicare Advantage, which are the Part C comprehensive plans that some folks are enrolled in, reimbursement for those is decreasing, and so you may see a reduction in the services that your Medicare Advantage plan offers as a result. So regardless of the type of insurance you have, I think here's what you need to keep in mind. Obviously it's important to, reading insurance plan documents is dreadful, right? It's complicated and technical and hard to wade through, and it takes a lot of time. But as you know, it's critically important that you do so. You have to make sure that your treatments are covered, are your doctors in network. As I mentioned before, the limits on out-of-pocket expenses only apply if so. And is there coverage for out-of-network services? I read that lots of the marketplace plans being offered are HMOs, and so they don't offer coverage for anyone out of network. And I know the little bit I read on the website before to prepare for this seemed to be that there are experts across the country, but that they're dedicated centers that you want access to. And so they may not be where you live, and it may be difficult to get insurance coverage for that. So be sure to understand, if you need to see someone who's not in your plan network, what happens then. There are a lot of resources that are available, particularly in the marketplace, to pick a plan, but I think the thing to keep in mind is you're still the expert on what you need and need to advocate for what's important to you. I think, it's unlikely that, and this is true for lots of patient groups I work with, it's unlikely if you go to a navigator, someone with training on the marketplace, and say, I need to know how OM is covered, they're not going to have any idea what you're talking about. The same is true for myeloma or hemophilia or any other rare disease. They're rare, right? So people don't happen upon them. It's important that you advocate for yourself. I wanted to mention one tool. This is the cancer insurance checklist that a bunch of cancer patient and provider groups got together to put this together. I brought 20 copies with me, and during the breakout was thinking we could walk through it in more detail, but this is a document where you write down all of the doctors you see, all of your prescriptions, everything over the past year that you've used, and it's a checklist to help you identify what plans are right for you. So this is just one of several tools that are out there to help you pick a plan. This one is cancer specific, so obviously I wanted to highlight it. Finally, if you want to learn more about the ACA, and who doesn't, right? It's so exciting. These are the resources that I would direct you to. Healthcare.gov, again, is the place to go for consumers. Even if you have a state-based marketplace, if you're not sure what it's called or where to find it, if you go to healthcare.gov and it works, and you put in your state, it'll shoot you to the right place, so don't worry about that. If you want to get more in the weeds on the policy, it's marketplace.cms.gov. I want to highlight the final link, which is a video that the Kaiser Family Foundation, which is a think tank in DC, put together using cartoon guys to talk about. It's 7 minutes long, and I really should have just shown you the video for 7 minutes and then answered questions, I think. But it provides a really good, clever, easy to understand overview of everything that's happening next year. So if you want to be entertained, at least, as you learn about the ACA, I would direct you there. So, are there any questions? Yes?
You had mentioned that under the ACA clinical trials, the plans were required to cover routine costs. What about grandfathered plans? Are they exempt, or are they also required to cover?
I believe that grandfathered plans are exempt. But let me scroll back.
Didn't say that.
Oh, sorry. Yeah, so grandfathered plans are exempt. Yes?
So you said that under the ACA, plans are required to cover the cost of clinical trials, but non-experimental agents. If an agent is already approved for a different indication, do the plans have to cover it, or is that, so an approved agent being studied for a new indication, is that investigational arm has to be covered, and doesn't have to be covered, or doesn't have to be covered?
If it's in a, If it's-
For example,
I guess it's for us, because it's experimental.
right.
I think the answer is going to be federally funded. I mean, it is.
Yeah, I would think that that would apply. I would think so.
Meaning that that the plan doesn't have to cover it? Or
That the
does?
plan, I believe that the plan would have to allow you to participate in the trial if you qualify, right? I mean, this is just what the plan does, right? There's obviously a lot of other stuff about if you qualify, but that they would not cover the cost of the drug, but they would cover your routine costs. I believe so. Yes. The sponsor. Right. Right. Any other questions? Oh.
Is there a place where we could get that cancer list online?
Yes,
Cancer checklist?
yes. It's, I believe it is cancerinsurancechecklist.org. And as I said, I have a bunch of copies with me, so if anyone wants to take it, I'm happy to pass them out. Yes?
If you have if you're an employee, you have like the traditional blues, like Blue Cross and Blue Shield, do they then have to do the same as the federal government's doing as far as the clinical trial information, or is that kind of up to them if they want to allow you to do clinical trials and you approve?
No, they should, the clinical trial stuff applies to, if you're not a grandfathered plan, it doesn't apply, but if you're any other type of private plan, it does. So if you have employer-sponsored coverage or individual market or whatever else, it should apply. I should say that I think the implementation of this provision could be a little bit tricky. HHS did not put out guidance on this particular policy, saying that they thought what was included in the law was sufficient, and so they didn't need to explain it any further. I think insurance companies may quibble with that, and so hopefully we'll see some guidance over the next year, but it should be all plans unless you're grandfathered. Comply with that. Yes?
Are there any changes that affect Medigap plans?
Are there any changes that affect Medigap plans? Not to my knowledge. Yes?
Employee-based plans, that considered grandfathered?
So an employer-based plan could be grandfathered, but isn't necessarily. So if you have a grandfathered plan, the plan has to tell you. So if they haven't told you, you probably don't have one. Plans change a little bit each year, right? That what's covered or what your copays are for different things, or they change around the margin. So those kinds of changes likely invalidate grandfathered status. So if you should know, and you can call your HR person or call your plan administrator and ask, because they have to tell you. I think. Okay, great. Thank you.